And now let's talk about the left ventricular function assessment. Actually, when it comes to assessing the left ventricular function, we add M mode in the parasternal long axis view, as you can see here, after the aortic area, the LVOT, and just below the mitral leaflet portion. Choose the most regular and continuous line, and it will represent the interventricular septum during systole and diastole as seen in the M mode. Here, as you know, in the M mode, the x-axis represents the time and the y the structures of the heart. First, here is the right ventricle, then here is the interventricular septum, then here is the left ventricle, and then the posterior wall, and then the pericardium. Now the device will ask you to sign the interventricular septum, so you will choose from here to here, and then it will ask you to sign the left ventricle. You will choose from here to here. Then it will ask you to sign the posterior wall. You will choose from here to here. It may not ask you for that, by the way. It varies according to the device. Some devices ask you also to sign the right ventricle. Then you sign the same measurements during the systole as seen here. Then the device will write you the ventricular dimensions and the 2D dimensions of the ventricle and the ejection fraction, which normally shall be greater than 55%. If it is lower, this means there is reduced ejection fraction. And now with the grading of the diastolic function or diastolic dysfunction. Actually, it is very important to grade the diastolic dysfunction in echocardiography. So here we add a pulsed wave at the mitral valve to see the mitral flow. As we know, it shall give us a parabolic curve of E and A wave. The E wave shall be greater than the A wave. Okay, that's the normal. But here, if the A wave comes greater than the E wave, this means there is a grade 1 diastolic dysfunction, which is impaired relaxation. If the E wave is much greater than the A wave, or the EA ratio becomes 1 to 2, which means the A is nearly half the way through the E, this means grade 2 diastolic dysfunction. If the A wave becomes too small, as you can see here, compared to the E wave, it is grade 3 diastolic dysfunction, which means less than the half. But now if the A wave starts to dissociate from the E wave, becomes further away, this means grade 4 diastolic dysfunction, which is irreversible. Actually, in grade 3 and grade 4, we consider it restricted. Let's talk about some normal findings that you may consider abnormal in the left ventricle. Here, as you can see, there is something called the false chord, which I signed here. It looks like actually the moderator band, which we will see later on in the right ventricle. Here, as you can see, a case which I recorded, it contains multiple masses, as you see here, in the ventricle with thrombi, which means it can send a shower of emboli. Here is the thrombi in the left ventricle. Here is a ventricular aneurysm. The ventricle has an aneurysm. Actually, in ventricular aneurysm, you may use a color Doppler to view the blood entering the ventricular aneurysm and filling it. And now with the wall motion of the ventricle. Actually, as you can see here is the septal wall, the anterior wall, the lateral wall, the posterior wall, and the inferior wall. We check the motion of each of these walls by adding the cursor of the echocardiography, as you see here, and check if it comes back and fro to the cursor. There is either akinesia, that the wall is not moving at all, or hypokinesia, in which the wall is moving but with a very slow speed compared to the rest of the walls, or dyskinesia, which means the wall has irregular motion. And now with the right ventricular assessment. In the right ventricular assessment, actually there is a lot of technique to assess the systolic function. First of all, there is a technique we can use by 2D planimetry and tracing the right ventricle once during the systole and once during the diastole to get the equation done, that is the right ventricular area during the diastole minus the right ventricular area during the systole over the right ventricular area during the diastole times 100 gets you the right ventricular outflow in percent, just like we done in the ejection fraction in the ventricle. Here is another method to assess, that is called the tricuspid annular plane systolic excursion. The normal method to do it is to add M mode at the most lateral part of the tricuspid valve and to start measuring the longitudinal displacement of the tricuspid valve. As you can see here, the length measured is the longitudinal displacement. It shall be above 16 mm for normal systolic function of the right ventricle. But actually, if we get it below it, it means that there is right ventricular systolic dysfunction. Is by using tissue Doppler imaging. Actually, we add a pulsed wave at the same area that we used before the tricuspid annulus, the most lateral part of the tricuspid valve, to see the tissue Doppler imaging drawing of it, and to measure not the longitudinal displacement only, but the velocity of the displacement. So if this velocity is less than 11.5 cm per second, this means there is ventricular dysfunction. And now let's talk about the detection of the pulmonary pressure. Actually, to detect the pulmonary pressure, you shall get a subcostal inferior vena cava view. Then you measure the inferior vena cava. If it is less than 17 mm, this means that the right atrial pressure is about 5 mm mercury. But if the inferior vena cava is more than 17 mm in diameter, which means you shall ask the patient to breathe or exhalation. If the inferior vena cava collapsed more than 50%, this means the right atrial pressure is 10 mm mercury. If the collapsibility index of the collapsibility of the inferior vena cava during exhalation was less than 50%, this means the right atrial pressure is about 15 mm mercury. If the inferior vena cava didn't collapse at all during exhalation, the right atrial pressure is considered to be about 15 millimeter mercury. Then we get the pulmonary pressure, assuming that the right atrial pressure plus the peak pressure gradient at the tricuspid valve equals the pulmonary pressure. Here, as you can see, the moderator band which I talked about before. Thanks for listening.
Please like and subscribe to my channel.